Hello, dear students. I am TIBBIYOT Zaimna. Your today's topic is joint syndrome. So this topic includes two main diseases: acute rheumatic fever or rheumatism, and juvenile rheumatoid arthritis. So acute rheumatic fever. Rheumatism is a systemic inflammatory disease of the connective tissue with a predominant localization of the process in the cardiovascular system, which develops in persons predisposed to it, and mainly young people, and is caused by infection with hemolytic streptococcus group A. So, in other words, this disease, named SAMARQAND disease, because this disease was first described by scientists of Buyot and Sokolsky. So the incidence of rheumatism ranges from 0.5 to 2% of the total population. The consequence of it are acquired heart defects. So rheumatism most often begins between the ages of 7 and 20. It rarely occurs before the age of 3 years and after 45 years. Women suffer from rheumatism almost 2 times more often than men. So the etiology of acute rheumatic fever is associated with streptococcal infection mainly. Rheumatism occurs 2 or 3 weeks after streptococcal infection, tonsillitis, scarlet fever, isolation of group A/B hemolytic streptococcus in most patients, an increase in the titer of anti-streptococcal antibodies, anti-streptolizine, anti-streptokinase, positive effect of antibacterial prophylaxis and treatment. In the development of rheumatic fever, in addition to infection, allergies play a big role. So as a result of contact with streptococcus, sensitization occurs and hyperallergic immune reaction occurs also. The interval of 10 or 14 days between a sore throat and the onset of a rheumatic attack is the latent period of the body's immune restructuring. So, acute rheumatic fever is an autoimmune disease. Streptococcus is a trigger factor for autoimmune aggression. Rheumatism develops in only 2-3% of people after streptococcal infection. Therefore, there is a genetic predisposition with a defect in immune defenses. So, streptococcus itself and its products have a pathogenetic effect. As streptokinase affects the joints, or streptolizine damages the heart. There are also degrees of activity of acute rheumatic fever. Certain maximum degree of activity, bright, general, and local manifestations, with fever, exudative component of the affected organs, neutrophilic leukocytosis, ECR more than 40, C reaction protein 3 pluses, a sharp increase in 2 globulins, fibrinogen, high titers of anti-streptococcal antibodies. Second stage is moderate degree of activity, moderately pronounced clinical manifestations with or without low-grade fever, without a pronounced exudative component in the organs. Acute phase and immune parameters are moderately expressed. ECR 20 to 40, a slight increase in anti-streptococcal antibody titers. And first degree is minimum degree of activity. Clinical symptoms and changes in laboratory parameters are mild. Also, there are 3 periods in the acute rheumatic fever. Clinical manifestations. First period, it is latent. 2 or 4 weeks after streptococcal infection, malaise, sweating, arthralgia, subfebrile condition. Second period, rheumatic attack. hyperergic reaction with organ symptoms, carditis, polyarthritis, chorea, or a combination thereof. And third period, increase in immunological disorders and progression of dystrophic processes, organ disorders progress, which determine the prognosis of the disease. Diagnostic criteria for rheumatism. There are two criteria, big criteria and small. Big criteria include carditis, polyarthritis, chorea, erythema, annular subcutaneous nodules. And small criteria is fever, arthralgia, history of attack of rheumatic fever, CR increase or increased C-reactive protein, leukocytosis, and extension interval PQ on ECG. Features of the rheumatic carditis. In 80–100%, the myocardium is affected. Often the process simultaneously affects the endocardium and myocardium. Complaints. Aching pain in the region, heart, slight dyspnea, palpitations, fever. Objectively, tachycardia, displacement of the boundaries of the heart outward, at the top weakening of the first tone, weak, soft systolic murmur. You can listen to the gallop rhythm, pathological third or fourth tones. Rheumatic endocarditis is the cause of at least 80% of all acquired heart defects. The mitral valve is more often involved, 2 times less often the aortic valve, and even less often the tricuspid valve. Myocarditis can be focal or diffuse. Objective symptoms: weakening of sonatory of the first tone, loss of a muscular component, systolic murmur of a functional nature at the apex of the heart, displacement of the borders of the heart mainly to the left, signs of heart failure. The last 2 symptoms are not typical for focal myocarditis. Systolic murmur may be a reflection of mitral regurgitation, the leading symptom of rheumatic valvulitis. It can be of different intensity, doesn't depend on the change in body position and phase of breathing. So associated with the first tone, takes up most of the systole, best heart in the apex of the heart and carried out in the left axillary region. So, laboratory studies reveal non-specific acute phase indicators, neutrophilic glycocytosis with a shift to the left, ECR positive CRP, hyperfibrinogenemia. So, immunological examination reveals the titer of anti-streptococcal antibodies. Additional research methods: ECG, violation of automatism of the sinus node, sinus tachycardia, or sinus arrhythmia. R wave voltage is reduced. Short phases of repolarization, the T wave is smoothed or disappears. Violation of the function of excitability ES. Mersization arrhythmia, violation of the conduction function, blockade, often AV blockade, and features of rheumatic polyarthritis. Large joints are most often affected. It is knee, ankle, elbow, shoulder, and wrist. Characterized by joint pain, swelling, redness, movement causes a sharp increase in pain. The contours of the joint are smoothed, cirrhosis, effusion into the joint cavity, and inflammatory edema of the periarticular tissue. The skin over the joints is hyperemic. Symmetry of the lesion, volatility of inflammatory changes and good quality of the course are characteristic. In 5 and 7% of cases, rheumatic nodules are detected in the area of the joints along the tendons. Rheumatic nodules, rounded dense from a few millimeters up to 1-2 centimeters, painless subcutaneous formations in the area of the knee, elbow, joints, occipital bone. They usually appear during the first attack of the acute rheumatic fever. Erythema annular observed 4 to 17% at the height of the rheumatic attack. Clinically pale, pink, annular, painless rashes on the skin of the trunk or extremities disappears with pressure. Usually it disappears without a trace within a day. Erythema annular and chorea. Chorea, a typical manifestation of acute rheumatic fever. In 30% of cases, as a rule, chorea is combined with other clinical syndromes of ARF, carditis, polyarthritis, but in 7% of patients, it may be the only symptom of the disease. Girls aged 6 to 15 get sick more often. The disease begins gradually with appearance of unstable mood, cheerfulness, later hyperkinesis, twitching of the muscles of the trunk, limbs, mimic muscles of the face, discoordination of movements, and decrease in muscle tone appear. Principles of treatment of acute rheumatic fever. Treatment of streptococcal infection is antibacterial therapy, antibiotics of the penicillin series. Suppression of the activity of the rheumatic process, NSAIDs. Correction of immunological disorders with fever, rheumatic heart disease, corticosteroids with a sluggish process, aminocholine derivatives, Delagil or Plaquenil. Anti-relapse measures include sanitation of foci of infection, year around Bacillin, prophylaxis Bacillin 5, and courses of anti-inflammatory therapy when signs of streptococcal infection appear. Spring and autumn, non-steroid anti-inflammatory disease drugs 4 to 6 weeks. This is the end. Thank you for your attention.